I'm Keith Coker, one of the other medical directors, along with Michelle. Welcome to the collaborative meeting. As Michelle was saying, we thought it would be worth resetting a bit on our quality initiatives, given there's so many new folks that are joining. So we understand kind of the basis for how we do our measurements, some of the rationale for why we're choosing the measures that we're focusing on. So that's what we're going to do here kind of in the next 20 minutes. And we'll do a bit of a round robin with this. It's not going to be like a really deep dive into it, but hopefully some nuts and bolts allow you to understand a little bit. And please, ask questions as they may come up, over the course of the day. Grab one of the team members here, because it's really important, I think, that we understand all this. So first of all, I want you to give you an orientation to how we actually do the measurement. So on the far left-hand side, where it says there's 4 abstraction modules, this is sort of more on the nuts and bolts of how we do the actual data collection side of things. So primarily with how the abstractors see their work, we organize the definitions of these cohorts or denominators like in this way, and kind of present this to the abstractors as sort of a task list. So kind of organize around head injury, in which case we have both sort of 2 quality initiatives, one focused on adults, one on children. The pediatric respiratory module that facilitates data collection around the use of chest x-rays, time to steroids, and then we have separate ones for pulmonary embolism and separate one for adult chest pain. And it's already been mentioned, we've retired one and we sort of paused another quality measure that's in the background. So that's kind of the orientation for the data collection process. I think the other thing that's important to understand is like, how do we even arrive at like which ones we focus on? Like, why are we choosing the ones that we are? And I think for us in the coordinating center, this is the way we think about that problem. It really begins with the evidence. What suggests high quality care? Where's the evidence out there that we can draw on to support better care? And that's coming from the literature, but that's also coming from recommendations and guidelines that are out there from our own specialty in emergency medicine, pediatrics. So that's what we're drawing on around the evidence. Secondarily, the opportunity. It's really critical to understand not just like what evidence suggests we do, but is there a gap? Do we have something to close here between where we're performing now and ideally where we should be performing? And so understanding that there's gap is really critical that we can begin to close. And then finally, impact. An impact can be measured in lots of ways, but we need to make sure that this is meaningful at the end of the day, meaningful to us, meaningful to our patients, and frankly, meaningful to Blue Cross. We have to be mindful of them as well. But I believe that there is correlation between all 3 of those folks, and finding alignment is important. So that's the sort of the Venn diagram of where we're arriving at which ones we choose to focus on. I think in our heads, like in the coordinating center, we organize these into 2 buckets. We think there's a lot of opportunity in that disposition decision, that admission discharge decision, because it is has such implications to how patients experience care, the cost of care that results. And so this fits into 2 of our quality initiatives around chest pain in adults and asthma and pediatrics. And then finally, probably more historically within Medic, we have this focus on imaging decision-making, particularly advanced imaging, CT imaging in particular for adults, but also this is where the chest x-ray work falls as well. And there's good evidence a lot of times about how you choose which patients to get this kind of imaging testing on. And there are implications, of course, around that, certainly with respect to cost, but also, radiation exposure, particularly in children, is important to be sure we're doing appropriately. So those are 2 categories that we fit our quality initiatives within. Okay, so now we're going to switch into, again, this kind of more lightning rounds This is the quality initiative. We're just going to sort of talk through it for just a couple minutes each. I get the adult head injury one, a little bit of some historical context within MEDIC. So when we launched this in 2016, we had a conversation across the network about what was going to be our gold standard clinical decision rule to apply, because there are actually a few to choose from. Canadian rule is the one we landed on because we felt like it had the best high quality evidence, the best between the sort of specificity and sensitivity of that rule. And so that's what we began to measure ourselves against. The big box on the left is all the exclusion criteria that we are applying to the cohort of patients with minor head injury. So if at the end of the day you feel like, gosh, like I feel like I'm seeing a lot more head injury patients than are showing up in my measurement, it's probably because we're applying this criteria because we want to cull down to that minor head injury population with which you should be applying this rule. Many of these elements are abstracted from the chart, and you know, so things like GCS and injury within 24 hours, you know, these are the sort of criteria that we're applying. I think probably a big one that excludes adults in particular is if you're on anticoagulation medications, you know, you're not in this denominator. And then finally, on the right-hand side is also abstracted chart information for the most part. And this is the things that we're applying consistent with the Canadian rule so that we know that the scan was consistent with that, so appropriateness. And so these are the elements that we're applying to those cases that go into that measurement. So brief kind of introduction to that. Please catch us when you have a chance if you have questions about it. I'm going to hand things over to, I believe it's, yeah, Michelle, you're next, right?
Thanks, Keith. Just to follow that up, and you know, one of the things is just trying to make that switch from appropriateness to utilization. So this year we're working on head CT utilization for children in the intermediate risk group using the PCARN rules, the Pediatric Emergency Care Applied Research Network rules that were published in 2010. Again, there were also some other rules we considered when we launched this. PCARN seemed to be the best, and so that's what was chosen. And our goal is to reduce the CT use in this intermediate group. And this intermediate group of kids is a little tougher than the low-risk ones, the ones that don't have many of the more worrisome signs. These might have a couple of signs, and it's divided by age, which I'll show you in a second. Similarly to Keith's slide, we also see the denominator exclusions, and I just want to remind everybody who's new in the room, these are available in our flow diagrams on the website too, so you can get those for your faculty anytime or in your talking points. So I just want to show you one other item that we have here, and that is just to remember about the pediatric intermediate risk group and PCARN in general. They broke their data up into less than 2-year-olds and older than 2-year-olds. Any clinician in the room knows it's hard to evaluate little kids. So the criteria to meet that intermediate risk are a little bit different for the younger kids versus the older kids. So again, when you're looking at those numbers, hey, you know, I thought I saw 1 billion kids with head injuries. We whittled it down to those kids who are involved, you know, and meet the criteria. So that's why the numbers may seem a little bit unusual to you. But we're focused in on this yellow group now, which is the just above the low risk. So we're in the intermediate risk group, okay? I'm gonna turn it over to Keith one more time. I'm getting our exercise here, our steps.
Forgot about that.
Got your watch.
Okay, so pulmonary embolism. So I know there's some controversy about this. But I think it's this is a measure that is oriented towards an outcome, and I think it's important to recognize there's a difference here. Many of the other measures are about process. We're measuring the process of the care decisions. For example, criteria for choosing whether to do a CT scan in a head injury patient. This one's about the outcome, and in part because I know this comes up a lot. This is really challenging care space, and even though we have good clinical decision rules that help us move through those decisions, they're not ones that are easily measured from the data available to us. And in particular, there's going to be groups of patients that you apply, say, the PERC rule to or the Wells criteria to, who don't then go on to get any testing, CT scans in particular. And therefore, we don't have like the indicator that that decision making actually happened. So we're unable to actually measure that process as a result. And so we're focused on the outcome, which is diagnostic yield. So the proportion of those scans that resulted in the diagnosis of an acute pulmonary embolism. Now we apply it to a cohort of patients that includes removal of those who are pregnant, because we know that's a more complex decision. We also cull it down to those scans that were ordered by the emergency physicians, emergency providers as well. And we do that through the work of the abstractors. And ultimately, that's the population. We're looking at the CT scans that are done for the indication of pulmonary embolism, and whether or not there was a diagnosis. I think the other thing I'll point out is we rely on the CPT codes for these chest CTs, but those codes are not specific for every indication of pulmonary embolism. So as you can imagine, chest CTs looking for an aorta problem, chest CTs being done for trauma indications, they can wind up into that initial cohort of codes. And so we rely on the abstractors to work through that within the chart to, again, identify those CTs that are being done for this indication. The rate at which we think diagnostic yield should be in an ideal state is uncertain. This is, to be honest, like leading edge kind of work. Nobody else is really doing this that I'm aware of. And I don't exactly know what the optimal diagnostic yield is. Right now we have sites that are performing at the level of, say, 11% of their scans being finding pulmonary embolism. And so we're relying on the distribution of that performance across our sites to understand where that target should be. And that's part of the target setting that we do each year with the executive committee. But I'll leave it at that. I'm happy to sort of take questions offline, because I think this is one of the more controversial topics in our measurement. Anyway, I'll leave it at that. And who's next? Courtney? Okay.
Good morning. So this QI goal is aimed at decreasing chest X-ray utilization for our pediatric patients with an ED diagnosis of asthma, bronchiolitis, or croup. We know that for this patient population, the chest X-ray is typically low yield and doesn't really change our clinical management. And so success in this measure is in decreasing the percentage of these children who receive a chest X-ray. In the same abstraction module, we also have pediatric asthma time to steroids. So for this measure, we're aiming to increase the percentage of children with asthma who receive steroids within 1 hour of their arrival to the emergency department. And you can see the exclusions for the denominator in the left-hand box there. We're not including the wheezing children under 2 years, and we're not including anyone older than 18 in this measure. We're also not including anyone who receives steroids within 24 hours of their ED arrival, or those who don't receive steroids at all during their ED visit. Notably, this is a sampled measure, so it's a random sample of up to 60 cases per site per month of this age group. That's the population that's abstracted and go into the performance measure for this initiative. All right.
Good morning, everybody. I'm Jason Ham. I'm the adult consultant to the medic team, and my passion is kind of that interface between the emergency department and the hospital. So admission is kind of something I really enjoy, all that gray stuff. So we're working on chest pain and looking at the percentage of low-risk chest pain that could appropriately be discharged home from the emergency department without observation. And we're looking at your intended disposition. There are some small chances that the patient could be admitted for some other reason. Maybe their cardiologist demands it or something, but if that's documented that that's the intended disposition, you win on that point. And so we're using a heart score, and there could have been some other scores used, but that was one that everyone's quite familiar with. So using a heart score and abstracting 80 cases per month per site. So one question, and probably this would be the pearl that I'd like to give in just short 4 minutes of time, is that there is a possibility of a difference between our abstracted heart score and what may be used in like MD Calc and those types of calculations. And to boil that down, it really comes down to documentation. And I know, roll your eyes, that kind of thing, document. But realistically, the pearl, I would say, is to try and tell people to dictate that one sentence that has high risk and low risk features, right? Instead of just saying chest pain, say why it's concerning and why it's not. And then talk to your abstractors. The abstractors are doing this, and they know every line that works in that. But the intent is, if you feel that the patient is a high-risk patient and you document that, even without even knowing every specific to the Bacchus story or Bacchus research and things, that patient will be above that number of 4 and up, and will be appropriately admitted and not picked up as someone that who should have been discharged. Yeah, and that's pretty much it. So that was my 4 minutes. And again, the other point is, if you have any questions, please come to me with any adult question, adult medic question, and be happy to either filter that to the right people or get back to you very quickly. All right, it goes back to you, Keith. Thank you.
Okay, so definitely seek us out if you have questions, like Jason was saying. I think it's really important to understand some of these fundamentals, because I think that will help clarify, how does the measurement work, and therefore sort of how the interventions functioning within your shop too, and what to expect around that.